Welcome to Midday Sessions, a podcast where I use creativity to imagine a different future, name the gaps between connection and community in the modern age, and examine the policies shaping our realities. Hi, I'm Nay, and today we're discussing H.R. 1, or the One Big Beautiful Bill Act, which was signed into law on July 4th, 2025. A year after its passage, we are beginning to see how its healthcare provisions may affect coverage, providers, states, and families. Because I live in California, I will focus especially on Medi-Cal, California's Medicaid program, which is funded jointly by state and federal governments. We'll look at what the law is intended to do, who may be affected, whether it can achieve its stated goals, and what communities can do in response. So, what is H.R. 1? Supporters introduced this bill focused on tax relief, reducing federal spending, and limiting what they described as waste, fraud, and abuse in the federal programs. In healthcare, the law changes Medicaid eligibility and administration. It adds new work and reporting requirements, creates additional documentation and verification processes, reduces federal Medicaid spending, and shifts more responsibility and potentially more cost to the states. Beginning October 1st, 2026, many lawfully present immigrants, including some refugees, asylees, and survivors of trafficking or domestic violence, will no longer qualify for federally funded Medicaid or CHIP coverages. Some children and pregnant individuals may remain protected under specific exceptions, but those protections are not universal. The law also affects medical education by limiting some federal student loan options for professional students. In addition, changes to Medicare physician payments could place further financial pressure on medical practices and healthcare providers. So, what problem is the law trying to address? It's responding to concerns about rising federal spending, Medicaid costs, fraud, and the national deficit. Supporters argue that reducing federal spending and adding eligibility requirements will make public programs more efficient and financially sustainable. However, these changes are being made within a healthcare system that are already struggling with high costs, unequal access, provider shortages, and gaps in insurance coverages. Many people rely on Medicaid and Medi-Cal for medication, preventative care, mental health services, pregnancy related care, and treatment for chronic conditions. So the larger question is, will reducing federal spending solve these problems, or will it simply shift the burden onto patients, states, hospitals, clinics, and families? Who will be affected? In California, 1 in 3 residents rely on Medi-Cal. These enrollees include low income families and individuals, older adults, people with disabilities, children, pregnant people, and some immigrants. For many of them, Medi-Cal is what makes basic healthcare possible. Losing coverage could mean a child going without asthma medication, a person with diabetes struggling to afford treatment, or someone living with mental health conditions losing access to care. These are not abstract policy outcomes. They can lead to worsening health, greater financial stress, delayed treatment, and more pressures on families that are already struggling. Patients are not the only stakeholders. Healthcare providers, hospitals, community clinics, rural healthcare centers, counties, medical students, state governments, the federal government, taxpayers, and healthcare workers may all be affected. Providers could also face additional eligibility checks and documentation requirements. That administrative work takes time and resources away from patient care. Hospitals and clinics may also see more uncompensated care if people lose coverage but still need treatment. Rural and community clinics may be especially vulnerable because they often operate with limited funding and already face shortages of doctors, nurses, behavioral health professionals, and other healthcare workers. Changes to federal student loan assistance could also make medical education less affordable. If fewer students can afford to enter healthcare professions, existing workforce shortages could become even more serious. What are the stated and possibly unstated goals of this law? The stated goals of H.R. 1 are to provide tax relief, reduce federal spending, prevent waste and fraud, and encourage people to go to work. But the law raises another question. Could one of its effects be to reduce the federal government's role in healthcare and shift more responsibilities to individual states? Another question. Could it also shift costs from the federal budget to hospitals, counties, patients, and families? These possible effects should not automatically be treated as proven motives, but they are important to examine because a policy's impact can be different from the way it's presented. When lawmakers describe people losing healthcare as a reduction in waste, we should ask, who is being defined as wasteful? Is it truly fraud, or is it someone who has difficulty completing paperwork, reporting work hours, finding transportation, or navigating a complicated system? Policies like this can place the greatest scrutiny on people who are already vulnerable. Their eligibility is questioned, their work is judged, and their need for assistance can be framed as a personal or moral failure. Yet these are often the same people who have the fewest resources to appeal a decision or challenge the system. Next question is, can the policy achieve its goals? The law provides broad goals, but several details make its long term effectiveness difficult to assess. We need to know how states will administer the new eligibility and reporting requirements, how much implementation will cost, how many eligible people might lose coverage because of paperwork rather than ineligibility, and whether the projected savings will outweigh increased costs to hospitals, clinics, counties, and state governments. We also need clear answers about what happens to people who lose Medicaid coverage. Will they qualify for employer insurance, Affordable Care Act marketplace plans, or other public programs? If they remain uninsured, who will pay for emergency care? Without those answers, it is difficult to determine whether the law truly reduces healthcare costs or simply transfers the cost from federal government to states, providers, and families. An analysis from the Budget Lab at Yale, published while the bill was still under consideration, warned that the legislation could substantially increase the federal debt and deficit while containing relatively few provisions designed to encourage long term economic growth. The analysis also warned that increased borrowing could place upward pressure on interest rates. That analysis was an initial projection based on the bill as written at the time, so it should not be treated as a final measurement of the law's real world effects. However, it does raise an important question. If the law increases deficit without producing comparable long term growth, where are the promised savings coming from? So, what are the probable impacts and equity concerns? The potential effects include loss of coverage, delayed treatment, increased medical debt, administrative burdens, provider shortages, clinic closures, and greater financial pressure on states and counties. These effects will not be distributed equally. Low income families may struggle to absorb new medical costs. People with disabilities may have difficult time meeting reporting requirements. Immigrants may face loss of coverage even while navigating complicated legal and financial circumstances. Rural communities may have fewer healthcare alternatives if a local clinic reduces services or closes. Children, pregnant people, seniors, and people with chronic illnesses may face serious consequences if care is interrupted. Historically, marginalized communities may also be more affected because they are more likely to experience lower wages, unstable employment, transportation barriers, language barriers, and limited access to technology. This is why an equity analysis matters. It is not enough to ask whether the law saves money overall. We also have to ask who pays the price for those savings, who has access to alternatives, and who has the power to challenge an unfair decision. So, what should change? My recommendation is that HR 1's healthcare provisions need a whole new overhaul. Any changes should protect continuous access to Medi-Cal and Medicaid, reduce unnecessary paperwork, and ensure that eligible people do not lose coverage because of administrative mistakes. States should receive enough funding to implement new requirements without cutting services or shifting costs onto counties and providers. Policymakers should also protect healthcare education and strengthen rather than weaken the healthcare workforce. Rural hospitals, community clinics, behavioral health providers, and safety net institutions need stable funding and payment systems that account for inflation and actual costs of providing care. Finally, people who lose eligibility should have a clear, affordable alternative source of coverage. No one should be left without medication or treatment simply because a reporting system is confusing or difficult to navigate. Now that we understand the larger and broader impact, what can we do? We can contact our representatives and ask them to protect Medicaid and the Affordable Care Act marketplace coverage instead of shifting costs onto patients and states. We can stay informed about our state and local counties' response to the budget changes. We can attend public meetings, support community organizations, help people apply or maintain coverage, and speak up before clinics close or families lose access to medication. Healthcare policies may be written in Washington, but its consequences are felt in our homes, clinics, hospitals, and communities. Staying informed matters. Speaking up matters. And collective action is how we make sure the people most affected are not left to fight alone. And that's all for today's episode of Midday Session, the podcast where we name the gaps, imagine something better, and examine the policies shaping our realities. If this conversation resonated with you, share it with someone who needs to hear it. And if you're feeling fired up like I am, let's keep the momentum going. Share your thoughts in the comments, connect with your representative, and remember, we are the ones we've been waiting for. Until the next time, stay curious, stay compassionate, and keep working toward a world where no one is left behind.